Hi, Nora.
Hi, Brian.
How are you guys doing?
We're doing pretty good. How about you?
Good. Doing well, thank you. I see that we have Dr. Bailey. We have, well, I just did something wrong, Skip. I apologize for that. Let's see. We have Judge Hargrove with us, which is excellent.
Hi, Judge Amaro. How are you?
Good. Good afternoon. Thank you for being here.
Absolutely.
So we are at 2 o'clock, and we're still lacking a few people. You might just have to wait a moment or two before we call the roll. I don't see Judge Harris with us yet.
I'm sure she'll be here momentarily.
I'm going to send her a quick text. And
I just got a text from Judge Harris asking if I'm in the meeting.
okay, well, you are.
I told her yes. Yes.
And I don't know that the Justice, I don't see Justice Boggs. I know that Emily Youngo was going to join us from the Chief Justice's office. All right, she said she's in the waiting room. She'll sign out and sign back in.
And Mara, you look very young. You have something different, a new hairstyle or something. You look very young.
Maybe it's my fancy cool glasses.
Maybe it's your fancy cool glasses.
It's
Yeah,
tortoise shell, you know, it just shaves 10 years off.
it does.
Oh boy, I don't see. Oh, I see somebody else joining now. All right, and Steve Kelly's also having some difficulty finding the link. Nora, do you have Judge Kelly on your phone?
Let me check.
Good afternoon, everybody. Wayne Senfeld here. Had a bit of a problem getting on, but
Hey, Wayne, thank you for joining us.
bet.
I do not have his contact information.
Okay, well, maybe he'll jump on soon. So we know that Steve is trying to join. I'm going to count him present. We have Sarah that's trying to join. I'm going to count her present. We have what appears to be a quorum. And so why don't we just get started? I'm going to call the meeting to order and welcome everybody to this meeting of the Involuntary Commitments Subcommittee of the Behavioral Health Reform and Innovation Commission. The goals of this subcommittee, for those of you who are new, are to reduce arrest, to reduce incarceration, to reduce hospitalization, and to examine and evaluate the involuntary commitment process so as to recommend improvements where needed, if needed. Today, we are excited to hear from our presenters, several of whom are committee members whose work is helping to get us where we need to go. Why don't I just turn it over at this time to one of our committee members, Nora Haynes, and she can introduce her group.
Okay, thank you so much, Judge Amaro, for allowing us to present the Opening Doors to Recovery project to you today. The two guys that are going to present, Dr. Michael Compton and Bill Carruthers, have been involved in this initiative for a very long time. Since 2004, Dr. Compton has been doing research on the CIT program that was required by DHR, specifically Gwen Skinner at the time. And we learned through this research that there is a huge value in community collaboration, sharing information, and especially forming relationships. We learned during CIT that police officers really do not want to take the most vulnerable to jails or prisons, but at the time there was not much else to do. So we began developing the Opening Doors to Recovery project, which was in 2010. It got funded, and from that time on, we have been looking at how to keep people with serious and persistent mental illness out of the deep ends and move them toward recovery. So at this time, we're going to start with Bill Carruthers, and then after he finishes, Dr. Michael Compton will give you the results of the Opening Doors to Recovery research project. So Bill, I am turning it over to you, and that is very scary.
You're muted.
Good afternoon, ladies and gentlemen, and I want to thank you guys for taking time out of your busy schedules and giving us the privilege and opportunity to be here with you today. It's monumental for us, obviously, and hopefully it will be informative and monumental for you as well. We're here today to talk about the Opening Doors to Recovery project, and this was developed starting way back in 2004. GBI and NAMI came together, created a CIT program. Shortly after that, 2009, there was the, everybody knows they were getting ready to close the hospitals down. And they had Nora convened a large group of people, and y'all know how that works. If you know Nora, then y'all kind of understand how that works. She brought together some of the smartest people that there were, and they developed this response to crisis report where they identified a lot of the gaps and the barriers to treatment, to blah, 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 and blah, blah, blah. We say that to say this, that a lot of the things that they identified that day are the same things that exist today. And it's really not monumental information when people tell me, I think we've identified the gaps and the barriers. But of course it was then. Also, we can look at back in 2010, under Nora's tutelage, they went and found some funding, because we all know you can't do this without getting some bread. And so she went to Bristol Squibb, CSX, and some other people and came up with a few $1 million. And at that point, let me see here. Oof. The Opening Doors to Recovery project was born. That time there was Dr. Compton, obviously, Nora, and they started to develop teams of community navigation specialists. Those teams were comprised of 3 different persons. One was a professional community navigation specialist, that we call them navigators. That was a clinician. There also was because we understand the importance to understanding the clinical nature of these processes, as well as the clinical nature of the illnesses that impact people, because so often people just think that it's something else. You just don't want it bad enough. You just ain't doing right, et cetera, when really there's a very clinical explanation for that. There was also a family member who was certified. And that family member, because we know that when a person is impacted by these challenges, that their families also are impacted. And a lot of, especially when we're talking about returning, if the family doesn't change their understanding and orientation, sometimes it's virtually impossible or extremely difficult for the person to change as well. And they also had a peer community navigation specialist, which was a person who was in recovery. And I understand that intimately. My name is Bill, and I'm a person in long-term recovery. And what that means, for about 40 years of my life, I was out there in the in the dark. Inactive addiction, serious and persistent mental health, criminalization, all of those things, and had no idea how to get out. So understanding the value to having a team where we can bring all of our best thinking together and then start to move people toward recovery. It gives recovery a whole different flavor, and it makes recovery very multifaceted in the pursuit. The focus of those were two chief goals: one, reducing institutional recidivism, and there's a couple different ways to look at that. Systems often look at what do we do inside a system to help people get better, or to get people better, or to, and a lot of times that becomes a systemic application that supports the system more than the person. And one of the things that I think used to lack, and we're really getting better at trying to address this, is that when people come out of those institutions or those systems and they get ready to go where? And that's where it starts to get dicey, because the majority of the time people go back to, and just the word back is counterproductive to the process of recovery, because recovery really should be a process of moving forward. I also have an intimate understanding of this part of the process because I was the original peer community navigation specialist. And in that pilot project, or I call it the testing the unmanned space flight, but anyway, and promoting recovery. And this is the greatest part, because what does recovery mean to each and every one of us? That can be something very different. With that being said, Opening Doors to Recovery had some pillars that it was built upon. Those pillars were ensuring adequate treatment. There's a difference between treatment, adequate treatment, person-centered treatment. There's a big difference. And a lot of times, because of money or because of time or whatever that is, the treatment that we apply to people is treatment that meets the needs of that system. I got to get this billing in on time. I got to get these notes. These progress notes have to pass a muster, and we got to make sure that, because that's the only way we can bill them out. A lot of times when you do that very well, the person gets lost in the process, and it's not person-centered. It is cookie cutter, and people end up where we think they should, instead of ending up where they really could, should, or would. We also understood that without securing safe and appropriate and stable housing, people have the possibilities of recovery are greatly lessened, because what that would mean for you, me, Nora, or Dr. Compton, that safe, appropriate housing would look different. So I know that there are a lot of models that have the best intents. We got some, people say you need to get housing first. But I'm gonna be honest with you, when I first came in here, fresh out of active addiction, there's still smoke coming off my head. If you would have put me in a house, it would have been a crack house, because I would have just figured out how to get rid of you. And from there, everything would have became unstable. Another one of the pillars is having a meaningful day, helping people understand how to have a meaningful day. For 40 years of my life, a meaningful day meant not getting or hiding from the police and getting a hit. So I didn't know any other thing. And if you suggested any other thing, it didn't have meaning for me, because I didn't know what that meant, and I didn't know what you meant. So also understanding the use of technology to promote recovery. And we all know that technology is challenging, because it's a miracle we all even made it into this meeting and we got technological support. So you know, a joker that's just coming out the woods with a flip phone, man, recovery is really dicey, and technology is dicey, but you can't fill out an application. You can't make a phone call. You can't respond. There's so many different things. So that was one of the things. Another components of that was the proverbial blue ribbon task force, which is collaborative fusion, bringing those stakeholders together, because together we are stronger And then if we learn how to hear each other together, we really things exponentially start to get better. Also, there was the GBI, GCIC supported linking system between police and CNS. That was a process where we enrolled people into a system, that system approved by GBI. So when people encountered law enforcement in the field, there was a caveat on that screen that said this person is part of an ODR project. Dispatcher, call this number. And I remember I used to get a phone call with 2 o'clock in the morning, 3 o'clock in the morning, or whatever time it was. And we had a response time because Nora said, Bill, I want you to be ambitious. My response time was 15 minutes. So whatever that means, Bill, you need to strap your phone to your head when they call. I want you to be there 15 minutes. It's Savannah, Georgia, right? So I say that to say this. The next thing we understood, the vitalness of a circle of support. We understand that once you get the person in the middle, and then once you get these other things to start to rotate, then we understand the importance of bringing our systems together and up to speed, because one of the things that we came to understand is that a lot of us do what we do very well, but we don't do it together very well. Because everybody's feeding their own dog. Everybody's making sure my yard is clean. And you kind of think about it, when you got that person that lives next to you and their yard is all unkempt and vines are crawling over the thing, you are really upset because you are saying you are messing up my yard. And you may not be as concerned about helping them get their yard together, because if both of us get our yard together, then the property value doesn't go down, et cetera, et cetera, et cetera. So it's kind of the same thing with our systems. As our systems start to work together better, because it's everybody's problem, it should be everybody's solution. We identified that very early on, and with Nora's encouragement, things really started to exponentially get better because people started to work together. I say that to say this. Did it work? Yeah, it really did work. And not only did it work for people, because it was built on a belief. Now, this is the thing. It's hard to believe, because when I was the person that you see on the left, it was impossible for me to see the person that you see on the right, that person that was working in a recovery system, that person that ended up working with CIT all across the country, that person that has an intimate relationship with Dr. with Dr. Compton and Nora and Judge this and Judge that and Sam Cochran and all those people. I could never have seen that for myself. I could never have seen myself as that other person, even though people used to always say to me, you're a really smart dude, man. Why don't you just get it together? I didn't understand how to do that. I couldn't do that by myself. I couldn't. And through the support of some really smart people, and also I want to say this, not only did Open Doors to Recovery exponentially improve the possibility of people coming into recovery and living lives of recovery, but it also exponentially changed our provider network. Because if I remember correctly, I was the first person in that agency working in recovery, right? And I vividly remember what happened the very first day I came to work, because I used to receive services there. And when I came to work that first day and I had my little badge on and all that stuff, and I told the lady, could you buzz the door so I can get in the back? Let me just say the door didn't buzz. She said, that's Bill Carruthers. If you let him in the back, we're doomed, right? And it took a very, very long time and some support of some very powerful people for me to have this chance. Because the first thing that they flagged on me was my criminal history. Dbhdd hit me up on the phone, hit the brakes, and it was Nora and June Dbhdd and them that told him he deserves a chance. And they gave me a chance, and that chance today, I am the project developer for the Rockdale County Stepping Up Initiative. Today, I'm living a life of whole health and wellness. Today, I'm sitting here talking to you. So if you don't think that means it works, you probably need to get your thinker checked. Also, I'd like to say that we understand that fragmented inaccessible community services. Just because you say you're one doesn't mean you're a good one. And just because you have one doesn't mean people know how to access that. Unengaged local stakeholders, we understand that everybody on this screen really in their heart of hearts wants people to get better. Wanting people to get better and being able to facilitate the process of miracles is a totally different thing. Because if you would have came up to me and you were as kind as you wanted to be, as well-dressed as you are, as smart as you are, just the fact of who you are and the way you look would have kept me from responding to you in any way, because I was so beat down, knocked down, stomped down. And when I looked up, I couldn't see you. That's why I spent most of my time looking down. Frequent police contacts. I remember when we went to Vegas and did my life story, and they calculated how much it cost to keep me in boxes over a period of 40 years. And I think the price was like $2 million of taxpayers' money that was kept me in state hospitals, kept me in jails, kept me in different systems. When if you would have taught me how to make $2 million, and if I could have understood that that was possible, change maybe could have happened a lot earlier. A limited support of recovery for recovery. I'm be honest with you, I know you guys have seen the exponential change of recovery systems over the past years. When I came in, you know, I did, wow, today I'm a certified peer specialist for addiction, certified peer specialist for mental health, certified peer forensic peer mentor, a certified psychiatric rehabilitation practitioner. I didn't even know what those things were. How do we expect people to become something when they don't even know what it is? And then when I presented that to the people I worked with, they didn't know what it was either. So I just say that to say this, those are the things that created the institutional recidivism. Those are the things that create a lack of personal recovery. Today, I have the opportunity to take programs into the jails. We have a recovery community organization, creating a diversion center, partnering with law enforcement, doing follow-up for co-responders. With the ODR project, there's a built-in co-responder model. There also is the built-in potential for AOT and all of those things that we're here talking about, because at the end of the day, this problem is not your problem. It's not my problem. It's not someone else's problem. It's our opportunity to create a solution. Anyway, with that being said, here's a list of some of the partners we had at that time and still have. With that being said, I'm going to turn it over to Dr. Compton, and thank y'all for your time.
Dr. Compton, let me interrupt just before you get started and ask Bill a question. Bill, you, in one of your slides, I think it's the second or third, it's the bullet point is a GBI, GCIC supported linkage between the police and CNSs.
Yes, sir.
Can you describe for me a bit more fully what that looked like?
Okay, so what that looked like is, and like I said, so GBI authorized us to put that caveat on their screen. We enrolled people into the program, and when we rolled them into the program, they signed a release. So that way all of the systems could speak to each other and it wouldn't be a HIPAA violation. And what that meant was when one of those people engaged law enforcement and they entered their name into the terminal, at that point, that caveat, everybody would get an alert. What that meant was that policeman in the field that just encountered that person knew then that that person was supported by the community service board. They knew that that person was part of a program, so they could call that number, and that means the entire complement of clinical information about that person. That means that we had seen that person at least once that week or twice that week, and we knew where they were. Or is their medication up to speed, where they're at in their recovery? So we could bring that information to the officer in the field. And if that person hadn't done something egregious, then instead of them having to go to jail, they would go with us. And we would take them to the appropriate place.
So this was...
Judge Amaro, Michael Compton is going to really get into that in a minute.
Then we'll wait. Thank you, Bill.
Okay.
Thank you, Nora.
Okay.
Dr. Compton.
Bill, if you'll stop sharing, I'll start sharing just so that I
Okay.
can.
Absolutely. I think, let me go here. Stop share. Poof.
Okay, let me see if I can do this.
I'm betting on you, Dr. Compton.
And how about that? Can you all see that?
Yes.
Yes.
Yep.
What is it that you're trying to show?
The same slides that Bill had.
Okay, yes.
I'll just real quick introduction of myself. I'm a community psychiatrist, and I worked for years at Grady. Thus, the connection between my work and Georgia. I'm now at Columbia University, and I do full-time research. I don't see patients anymore. I do research, and pretty much all of my research focuses on this interface between people living with serious mental illnesses and the criminal justice system. Projects all the way from working directly with police officers and the CIT program, all the way through to young people with early schizophrenia in jail at Rikers Island. And so I'm going to be sharing some of our research results from the Opening Doors to Recovery project, or ODR, as I'll call it. But let me just real quick explain what I do as a researcher. I basically do four things. I write grants and hopefully get grants. So a lot of my time is spent writing. And then I carry out studies. The third part is I write articles. So again, a lot of writing, articles that get published in the peer-reviewed literature, and I'm going to be sharing with you 8 articles on opening doors to recovery. I'll sort of gloss over some of them and go into a little bit more depth on others. And then the fourth sort of activity as a researcher is that I share my research findings, the new knowledge that we've generated with policymakers. And so that's sort of what I'm doing for this hour of my day, hopefully sharing with you all the new knowledge that we've generated through these research grants, the articles that we've written, and now this great opportunity to turn this information and knowledge over to you all as policymakers. I think this is the slide where Bill, who I've known for probably more than a decade. I knew him back when he had black hair, and he knew me when I had any hair. So Bill and I go a long ways back. So do I with Nora. I first started working with Nora on Georgia's CIT program, which over the years has become an exemplar program in terms of CIT. At any rate, these two pictures here are showing all of us as we created Opening Doors to Recovery back with Governor Perdue, and then a few years later with Governor Deal. The point here is that the creation of ODR really was not only a very collaborative process, but also garnered support from the very beginning from some of the highest levels of government. This slide shows those same two outcomes that Bill was just talking about, the institutional recidivism. We also call it in and out of the deep ends, in and out of jails and prisons, in and out of inpatient psychiatric units, and in and out of homelessness. Those are the three deep ends or institutional recidivism that ODR really wanted to target to try to address. And then secondly, personal recovery. That is above and beyond the deep ends. Are you really recovering? Are you engaged in life and your family and your community? And so we felt that in designing ODR, in order to target those two outcomes, we needed this team of navigators, which Bill has described, They would do community navigation, which is a little bit different from case management, as I'll describe. They would need multiple collaborative partners. They would need this special police CNS linkage system, which Judge Amaro, you were just asking about, and I'll try to get into that shortly. It's one of the many, many ingredients of ODR, but it's a really, really unique ingredient that I'm actually studying right now in Atlanta and in South Georgia. In and of itself, aside from all of the other ingredients of ODR, we're studying just that linkage system itself. And then you need recovery support, and all of this, the 4 pillars of ODR, as Bill described, are about ensuring adequate treatment, maintaining safe housing, developing what we call a meaningful day, and then using technology to support recovery. I'm not going to go through all of these details. This slide and the next are simply trying to compare ODR to 3 other forms of outpatient wraparound care for people with SMI. Community support teams, which are available in some CSBs in Georgia, ICM, which is a very commonly used form of case management, and then finally ACT, assertive community treatment. And the bottom line here is that ODR was designed to be roughly the same level of intensity as ICM, intensive case management. Probably a little more intensive than community support teams, but not as intensive as assertive community treatment, which importantly, although it exists in Georgia and many other states, it's hard to support ACT just because of the level of staffing and cost involved. Opening doors to recovery, the overarching focus is about, as I've mentioned, reducing inpatient and criminal justice recidivism, and then promoting recovery through community navigation and focusing on things like a meaningful day. Whereas intensive case management, probably the most common form of case management in Georgia, as detailed by Dbhdd, is really more about identifying needs and minimizing symptoms that interfere with recovery. The ODR approach never really talks about symptoms. In ODR, we feel that symptoms are less relevant to your recovery than having safe and stable housing, having a meaningful day, having good access to treatment, etc. So this is sort of a slight philosophical difference between ODR and some of the other models. In terms of ODR, how it was developed, as Bill mentioned, this was a big collaboration. We got initial funding from BMS Foundation. They took an interest in what we were designing and gave us funding not only to implement ODR in Southeast Georgia, but also to study it. And so we carried out a study, which I'll describe, involving 100 participants with serious mental illnesses in the Region 5 of Southeast Georgia. So let me run through some of the original articles that we wrote, and then I'm going to get into some of the actual research details from the original study, and then more importantly, from a recently completed NIH-funded large-scale project of ODR. So the first article that we wrote back in 2011 was really just describing the ODR model. This was published in the journal Psychiatric Services, and we really focused on the partnerships that went into developing ODR. We detailed how ODR was informed by ACT. It was very much informed by Georgia's Certified Peer Specialist Program and the overall national movement toward peer support. It was also informed by Georgia's CIT program and the overall recovery paradigm. And as I've mentioned, ODR really focuses on trying to reduce the number of days spent in inpatient psychiatric units, in jails and prisons, and in homelessness, the deep ends. We also talked about, again, the collaborative spirit of ODR. Bill referred to this as that collaborative fusion where we bring the stakeholders together around the table, whether it's mayors, sheriffs, faith-based communities, mental health providers, the local emergency departments. We explain the model and we say we've got a group of patients who are being cared for following the ODR model, and we want all of you to be involved to help us reduce their institutional recidivism and promote their recovery. So bringing together partners that usually aren't necessarily at the table, whether it's Parks and Recreation to the Department of Labor to the local housing authority. That's what we did in Southeast Georgia. So the next article that we wrote was really just about the training curriculum that we send ODR navigators through. ODR navigators. This is the professional CNS, the family CNS, and the peer CNS. This was published in the Community Mental Health Journal. We talked about how we assessed 14 new navigators in terms of their knowledge and also in terms of their confidence for working with people with serious mental illnesses. And we were able to show that from before the training, the 1-week training, until after the training, they had improvements in knowledge and improvements in efficacy, self-efficacy. Now, this might seem like a relatively simple study, and it was, but the first step to really showing that ODR works was to show that we can train ODR navigators to do the work of community navigation and to do it successfully through a fairly rigorous training. We then did what's called a process evaluation or a program evaluation. As we were enrolling the 100 patients into the initial project, we were also running around doing interviews with those patients, with family members, with ODR navigators, with mental health administrators, etc. We published this program evaluation also in this journal, Psychiatric Quarterly. And here we really wanted to, again, describe ODR and then talk about what various stakeholders view as its strengths and weaknesses. These are some of the described hopes for ODR. The participants in these interviews talked about, we really hope this will decrease recidivism in and out of jail, in and out of the hospital. We really hope that it'll identify and close gaps in the system of care. We really hope that we can figure out sustainability and dissemination, etc. And these were some of the commonly mentioned strengths. For example, one of the philosophies of ODR is you do whatever it takes. The navigators do whatever it takes to help their clients have a meaningful day, whether that's a fishing trip or a trip to the grocery store, which is something that traditional case management or intensive case management might not do. We'll do it in ODR, whatever it takes. These were some of the reported challenges and weaknesses. Always when we do interviews, we find that insufficient housing resources is way up there as a barrier. You know, we can do great work on the mental health side, but if we don't have enough housing, it's always going to interfere with people's ability to engage in recovery and stay out of the deep ends. So that was sort of the third article that we wrote on ODR. And then once we completed the first study with the 100 patients, we published this report, which really laid the ground for the big study that I'll be telling you about that we just recently completed last year. These are some of the findings from the 100 patients that we enrolled in Region 5 in Southeast Georgia. We can see that in the year before their enrollment in Opening Doors to Recovery, their average number of hospitalizations was 1.9. In the year being in opening doors to recovery, their average number of hospitalizations was 0.56. That's what we call a statistically significant difference from the year before enrollment to the year of enrollment in ODR. In terms of hospital days, 28 days in the year before enrollment down to 15 days. That's almost cut in half. Again, it's what we call statistically significant, meaning that difference can't just be due to chance. There's got to be something that's causing that difference. And, you know, we would hypothesize that it's being in opening doors to recovery, but that's causing that difference. In terms of the mean number of arrests and the arrest rate, we did see a decrease, but this was not deemed statistically significant. So there was a signal there, but not one that we could call statistically significant, meaning that we're not sure. That little difference might be due to chance. So this is just a bar graph showing that difference in the number of hospitalizations in the year before ODR and the year during ODR, and the number of days being hospitalized. This is Dbhdd data. We did not just like ask the patients, hey, were you hospitalized? This is data that was directly from Dbhdd. We also, over the course of 12 months with these 100 patients in Southeast Georgia, we looked at their recovery outcomes across a number of measures from baseline to 4 months to 8 months to 12 months. This is a lot of data. I won't go through it all, but just as an example, this QALY is the quality of life inventory. Are you able to see my cursor as I move about? No, okay. I'm sort of using it on my end, but I understand that you don't see it. If we just look at the row that says QALY, or quality of life inventory, at baseline, the average score was 21. 4 months into ODR, 27. 8 months into ODR, 29. 12 months into ODR, 32. So you can see that as we go along across the year working with the ODR CNSs, quality of life is improving. And the same is true for most of these other measures of recovery. And then if we look at measures from the navigators, not directly from the clients, but from the navigators, we also see improvements. So if we look at daily living activities, for example, at 4 months, the average score across the 100 patients is 90. At 8 months, 96.5. At 12 months, 99.7. We see improvements across time in these measures. As we were going along in that main study, we also got really interested in this thing that ODR had invented called the Family CNS. That's a whole new job description that ODR created, because they felt, okay, we've got licensed mental health professionals, we can have a professional navigator. Thanks to Georgia's CPS program, we've got peer specialists, so we can put a peer specialist on the team. But when we were developing ODR, we said there's a team member who's missing. We need a family member who's been through the navigation or the difficulty navigating services. And so we created this new position, this full-time position called a Family CNS, a family navigator. And because that was a pretty unique thing to do, we went ahead and studied that, the family navigator role. We wrote an article about that, and this article's been cited a lot. In fact, there are other programs popping up across the country that now utilize this new worker, this family community navigation specialist. We also, as a research team, got really interested in this idea of a meaningful day. I mean, I had been a psychiatrist for years, and I know about symptoms and functional recovery and, substance use recovery, but what's this meaningful day thing? what's that? I've never heard of such a thing, even though it's one of the pillars of this ODR approach. So we studied this meaningful day concept and wrote an article about meaningful day as a potential new recovery concept. I published this in the Community Mental Health Journal. We measured a meaningful day across baseline 4, 8, and 12 months among these 100 patients referred to ODR. We gave them a thermometer and said, you know, rate how meaningful your average day is on this thermometer. And they drew a line on the thermometer how meaningful your average day is. At baseline, the 100 clients rated 57. 4 months into ODR, 64. 8 months into ODR, when I sent my research assistant into the patient's home and completed the assessment again, including this meaningful day thermometer, 70. And by 12 months, it was up to 72 compared to 57 at baseline. So things are getting better among these ODR patients in terms of meaningful day. We also measured their number of meaningful days in the past 30 days, and that got better. So this is an interesting, but I think super important concept of ODR that other psychiatric outpatient programs do not attend to, like ACT, ICM, et cetera, this meaningful day concept. And I've come to believe that if you're not having a meaningful day, it's very hard to engage in recovery. It's very hard to stay out of the deep end. It's hard to take your medications. It's hard to go to your doctor's appointments if you're not having a meaningful day. This is just a quote. I'll pause briefly so that you can read it, that sort of describes this meaningful day concept. So the clients are really telling us that a meaningful day is about being productive. It's about a good quality of life. It's having something to do. And you can imagine that those things help you to stay out of jail, stay out of the hospital, take your medicine, etc. So after 6 articles and some pretty good looking results, we felt that we were ready to go ahead and write a big grant proposal to submit to the NIH in Bethesda. Knowing that these grants are very, very hard to get, but we felt that we had some compelling preliminary data. The biggest flaw to our data that I've presented so far is that with these 100 patients that we studied in the year before ODR and then the year of ODR, maybe their improvements were in fact due to ODR, but there's a chance that their improvements were due to something that we as scientists call regression to the mean, which means, okay, you were really sick in the year before ODR, you were in and out of the hospital, we enrolled you into the project when you were in the hospital. Maybe those improvements that we observed over time, over the year of working with the navigators, was just you sort of getting back to your normal state. Maybe it's just regression to the mean. And so we needed to design a trial, a study, a research project that would once and for all prove whether or not ODR is effective. Not just give us good information, not just a very strong signal, but solid proof. And so what we did is designed what's called a randomized controlled trial. And just real quick, I want to emphasize the importance of a randomized controlled trial. It's the gold standard for any kind of medical treatment. All of our medications that are FDA approved have gone through an RCT, a randomized controlled trial. And there are at least 2 key ingredients to this type of study that are so important. One is the randomization. So in in the original Opening Doors to Recovery project with 100 patients, we handpicked the patients who we thought would be most suitable for ODR. So there was some potential bias on our part in terms of who got into ODR. Another approach would have been, we could say, hey, do you want to go into ODR, or would you rather go into let's say, intensive case management? Let the patient decide. That's not a good approach either, because then the patient is getting to decide. A randomized study is where the computer flips a coin for you and the patient either goes into your treatment or some other treatment that you're comparing it against. So the randomization is very important because it washes away all the other possible causes of the outcomes that you're going to observe at the end of your study. The other part of a randomized controlled trial is that you have control over some of your data, and your data collection is blinded. So that as the researcher, I don't know if you're in the ODR group or the comparison group when the data are collected. Therefore, there can be no bias. And so our two main types of data come directly from the state of Georgia, from Dbhdd. When they gave us the data, they didn't know if this patient was in ODR for the past 12 months or was in intensive case management for the past 12 months. They were blinded. And the second major source of data came from the GBI, from the participants' rap sheets, which they had given us consent to collect. And so that blinded nature of the data collection is another key ingredient. So we carried out a 12-month randomized controlled trial involving 240 patients in the Gateway CSB footprint, these 8 counties in coastal Georgia. This project went on for 5 years. It was a $3 million project funded by the federal government. It covered some of my time, 20% of my time for 5 years. It covered 3 navigators in this Gateway CSB. It covered a full-time research coordinator, 2 research assistants on the ground going into patients' homes, going into hospitals, enrolling patients, randomizing patients, etc. We wanted to look at hospital recidivism. We wanted to look at arrests. And then finally, our secondary outcomes related to housing outcomes and recovery-related outcomes. So 240 patients enrolled as they were coming out of the hospital. We did a big research assessment, and then they got randomized by the computer to either get sent to the ODR team or to get sent to traditional case management, as defined by Dbhdd. I'll tell you about our main results. This paper is currently submitted to a really, really good journal, and I'm hoping that it's going to be accepted any day now and then published. It shows the main findings. This is a figure from the article. It basically shows that over the course of about 3 years, we were referred 375 patients who we assessed for eligibility. Some of them were not eligible based on our criteria. We started a baseline assessment on 251. We actually randomized 240, which was our target. We told the NIH at the beginning of the project we're going to enroll 240 because that's what the statistician says it's going to take. They got randomized. 117 got allocated to ODR. 123 got allocated to case management. We did this over the course of 3 years, and the navigators never had a caseload of more than 30 because we were cycling patients into the project. They were in for 12 months. They got cycled out. Another patient got cycled through. So the caseload was up to 30. In terms of case management, if the patient resided in Chatham County, Savannah, Then they went into intensive case management as defined by Dbhdd, carried out by Gateway CSB. For the other counties, they don't have ICM, they have regular case management. So for the 30 or so patients who lived in these other more rural counties, they were in case management as opposed to in Chatham County, it was intensive case management. So I'm not going to go through all of these numbers. The bottom line here is the average age was about 36, about 65% were male, about half were white, about half were black, about 62% were single and never married, and 87% were unemployed at the time we enrolled them in the project. For all of these comparisons between ODR and case management, every single one of them is not statistically different. And that's because of the beauty of randomization. That's how randomization works. It gives you these two groups that are the same on every factor that we can measure, except the one factor that we really care about, and that is, were they in ODR or were they in case management? These were their diagnoses. About 65% had a psychotic disorder like schizophrenia, 21% had a bipolar disorder, about 14% had a major depressive disorder. When we enrolled them into the randomized controlled trial, they had been in the hospital for about 11 days or so and were just about to be discharged, and that's when they were randomized to either ODR or case management. A lot of numbers here, but let me just show you some of the more important ones. In terms of number of days hospitalized over 12 months, the average in the ODR group was 18 days. The average in the case management group was 21 days. That's what we call statistically significant difference. And we know that it was driven by one variable, and that is which group they were in. In terms of the arrest rate, the proportion who had been arrested in the ODR group, it's that number in parentheses, 20.5. 20% of the patients in the ODR group got arrested. In the case management group, 39.8%, so 40%, 20% compared to 40%. And again, the 40%, those patients are not in nothing, they're not in no care, they're in the standard of care. They're in intensive case management in Chatham County or case management in the other counties. About 100 of them were intensive case management, and roughly 30 or so were in traditional case management. We also see in terms of the time to the first arrest, there's a difference, 11 months in ODR compared to 9 months in the case management group. We see differences in housing satisfaction, in the recovery score, in their sense of empowerment, and in their community navigation abilities. So this is really what proves that ODR is more effective, more efficacious than traditional case management and intensive case management services as defined by Dbhdd. Now, the finding that was most impressive to me was this 12-month incidence rate, the percentage of patients in the two groups that got arrested. So we did a little bit of a deep dive into this and looked at, well, what are they getting arrested for? So among these 240 patients, 171 had ever been arrested in the state of Georgia when we enrolled them into the project. 71% had been arrested in the state of Georgia when we enrolled them in the project. We looked at their actual charges from their rap sheets. These are the most common charges, rank ordered. And by the way, the average number of arrests, if you've been arrested, if you're among the 71% who's been arrested, The average number of arrests was 8.6. Remember, their average age is 36 years old. They've been arrested on average 8.6 times. Their average number of charges, 12.6. So a lot of charges, a lot of arrests. We then looked at what were their first two ever charges when they were on average 20 to 21 years old. This is the first column on the left is the ranked list of their most common charges. Their first two charges when they were 20 to 21 years old on average, compared to their most recent two charges when they're on average between 33 and 35 years old. And it's interesting because we see that they started out early in their illness with the usual sorts of suspects like marijuana possession. That gets way less common later in their illness, but things like disorderly conduct gets way more common as they have, settled into this chronic form of mental illness. Then we start to see obstruction charges. The third most common charge among people with serious mental illnesses is interfering with the work of a police officer, a misdemeanor. The ninth most is interfering with the work of a police officer that's a felony. In other words, they're not having good interactions with police officers, and you have to wonder why that is. We also see probation violation, failure to appear to court. They're not keeping their appointments very well. That's what probation violation is, as far as I can tell, or failure to appear to court. The number one most common charge, probation violation. I know I'm sort of preaching to the choir, but the bottom line is our patients mostly get arrested for minor misdemeanors. I'm going to wrap up soon. I just have a couple more slides from a paper that we're just about to submit to a journal that thankfully a health economist helped me to do. She did the numbers for me. She was at Columbia. She happens to be at NIH now. What she did was she calculated all of the hospital costs based on the data that Dbhdd gave us for both the ODR group and the overall control group. So just look at the first column of numbers and the last column of numbers. The total cost for the ODR group was, in terms of hospitalization, was $670,000. For the control group and case management, $852,000. And when you average that across the patients, it's about $5,700 per ODR patient for the course of 12 months, and about $7,000 per case management patient over the course of 12 months. When we look at criminal justice data, there's a way to calculate for every charge what is the estimated total cost to society, and that's what this health economist did. So if we look at assault, for example, in the ODR group there were 5 assault charges over the course of the year. Total cost was $202,000. In the control group there were a total of 7 assault charges with a total cost to Georgia of $281,000. And when we sum up all of these charges at the, after a year of being in ODR or being in case management, there were a total of 39 charges in the ODR group. I'm sorry, I should be saying arrests. 39 arrests in the ODR group and 108 arrests in the case management group. You see highlighted the total costs of those arrests and then the average criminal justice cost per client. $2,900 on average per ODR patient over the course of a year, $6,200 on average per case management client over the course of a year. So that's a lot of cost savings right there. And then when we go ahead and add up the costs of ODR and the cost of case management, you still see that even though ODR is more expensive because you've got 3 workers instead of just 1 case manager, there's still substantial cost savings for the state. I don't have slides, Judge Amiro, on the linkage system, but let me just spend maybe 2 minutes
Please
talking
do.
about ingredient. That's a very, very special ingredient of opening doors to recovery that was literally invented for ODR by Nora Haynes in conjunction with Vernon Keenan and his group at GCIC. And basically, it builds upon the existing GCIC process, the databases that are housed at GCIC. So as you know, when you get pulled over for a minor traffic violation, the law enforcement officer comes up to your car, takes your driver's license, goes back to his car. You're sitting in your car sweating bullets for about 10 minutes trying to decide, am I going to tell this cop that I'm a judge? Is that going to be viewed as good or as bad or what? Is he going to give me a citation, or is he just going to let me go with the warning? You're sweating bullets, you're worried. What he's doing in his car is he's putting in your identifying information from your driver's license into his in-car laptop, and it's querying a number of databases housed at the GCIC in DeKalb County. One of those databases is wanted persons. One of those databases is registered sex offender. One of those databases is warrant out for your arrest. One of those databases is you're under protective orders, etc. And if there's a match between what the officer put in and what's in one of those databases, the officer gets notified. There's a warrant out for this guy's arrest. That's what he's doing in his car while you're waiting for him to come up and either give you a ticket or let you go. We know that people with SMI have lots and lots of encounters with police officers, whether it's in a car or on a park bench. The officer always does this process. They run a query, a GCIC query. So what ODR did, never been done anywhere else, anywhere in the country or the world as far as I know. They created a new database at GCIC with all of our ODR participants in that database. So those 117 patients that went through ODR, there was a database at GCIC with all of their identifying information. Anytime a law enforcement officer in the state of Georgia ran a query when we were running this project, our database got queried also. If there was a match, what the officer saw on his laptop was a note. Bill referred to it earlier as a caveat. It's an administrative note that says this person is in a special mental health treatment program called Opening Doors to Recovery. Please call this number. That number was for a cell phone that went straight to whichever navigator was on call, whether it was Bill Carruthers or the Family CNS or the Professional CNS. And the officer, he's never seen such a thing. A phone number for him to call to talk directly to a mental health professional? Well, what about HIPAA? The patients enrolled in ODR sign a consent saying that they agree with this, they want this temporary pull down of HIPAA so that that officer can briefly have a conversation with the CNS, and the CNS can help him or her decide what to do. And maybe, just maybe, in a few instances, rather than a disorderly conduct, rather than a willful obstruction, maybe we can prevent an arrest. And so some of these arrests that you see on the screen may have been reduced in the ODR group because of that one ingredient of ODR. Now, there are a lot of other ingredients of ODR that would also account for reduced arrest, but that linkage system is one. And so what we're doing right now in both Atlanta and Southeast Georgia, the Savannah area, we've just completed enrollment in a project where we took 1,400 outpatients with serious mental illnesses and randomized them. This was another NIH-funded study, which I need to get on a whole different call to tell you about. We randomized them to either go into the linkage system and be in that database at GCIC or not. And at the end of 24 months, we're going to pull their rap sheets with their consent, and we're going to compare whether there's a difference in arrests between those in just the linkage system, no ODR, just the linkage system, versus not being in the linkage system. We're not going to know the results for about another year. So as a researcher, I can't really endorse this one single ingredient of ODR yet. But if you give me another year, I'll tell you whether it in and of itself is effective or not. We know that ODR as a whole composite intervention is effective. We've proven that. We've nailed it compared to case management. But the linkage system itself is still under study.
So go ahead, please.
Just my last slide, I wanted to mention what Bill has already mentioned, and that is because of these very impressive results from ODR, Rockdale County has decided to go ahead and implement ODR and fund ODR, and Bill is a big part of that. I also wanted to mention that I've got a NIH grant proposal that's about to go in again to do ODR versus another intervention called critical time intervention for people with SMI coming out of the Fulton County Jail. I'm working with Fulton County Dbhdd, the Fulton County Jail, et cetera, and we're hoping to be able to get that grant, which would be a 5-year project to study ODR for people not coming out of the hospital, but people coming out of jail. And I'll shut up there and turn it back over to you all.
All right, so these people are coming out of hospitals primarily, Dr. Compton?
The 100 that we studied and then the 240 that we studied were coming out of either hospitals or crisis stabilization units.
Okay.
And the project we're doing in Rockdale now is bringing those people out of jail.
And this linkage system, right, might just be magical in terms of its overall impact. But the GCIC patient consent repository.
And just one thing I would like to add, I know we're time sensitive, but the
Really
one thing I would like to add is the reason that Dr. Compton and both I were here today is because he gave some very qualitative and quantitative data about how that really works. And for me, being a person who used to be on the other side of this thing and being in this process, working with everyone here for about 10 years, I can say to a certainty that it works. And I think that's what we're looking for, something that works.
Thanks, Bill. Thanks, Dora. Thank you, Dr. Compton. That's extremely valuable. I'm just dying to see what the results are going to be of your broader GCIC patient linkage going forward. And hopefully you'll come back and share that with us. Let's shift now to the involuntary commitments piece with Judge Hargrove, who's put together an excellent presentation. Hers focuses in on what I would call where the rubber meets the road. She is someone who knows this corner of the universe better than anyone, and she's going to give us sort of an insight into what happens where she lives. Dr. Hargrove.
Yes, thank you, Judge Amaro. Good afternoon. I am Bedelia C. Hargrove, and I am the probate court judge of Dekalb County, Georgia. I am a member of the Involuntary Commitment Subcommittee, and it is a pleasure to be here today to present to you concerning involuntary treatment for mental illness in the state of Georgia. I want to thank Judge Amaro for asking me to speak today concerning this topic. Judge Amaro wanted me to talk about my experience with the involuntary commitment process through the years of my legal career, as well as during my time as the judge of the Dekalb County Probate Court. I also want to thank my colleagues, Judge Sarah Harris with the Macon-Bibb County Probate Court, who is also going to assist me today in my presentation. So I've had an amazing opportunity over the last 20 years of my legal career to be involved in mental illness cases. I first started as a court-appointed attorney and guardian ad litem for patients in Fulton County. I was later appointed as the hearing officer to handle all of the involuntary commitment proceedings in Fulton County, and then later as a substitute hearing officer in DeKalb County. And then, of course, for the last 5 years, I have served as the probate court judge in DeKalb County, and I have garnered even more experience in the mental illness cases. It was recently brought to my attention that DeKalb County may handle the largest volume of mental illness cases in the state of Georgia. While we are the 4th largest county in the state of Georgia, apparently the size of your county does not dictate the volume of need for the essential services concerning mental illness. So before I get started with my PowerPoint presentation, I just want to provide you with some current numbers that I have compiled concerning DeKalb County. Thus far in 2022, we have issued approximately 180 orders to apprehend. And of course, when those affidavits are filed and there is sufficient cause, those orders to apprehend are signed on the same day. We have processed 350 involuntary commitment petitions, and the hearings for those cases must be set within 7 to 12 days, which includes the weekends. We have also processed approximately 60 emergency guardianship petitions, and those cases must be set for a hearing within 3 to 5 days, which includes the weekends. And we have also processed approximately 120 permanent adult guardianship petitions. The reason why I'm telling you about the guardianship petitions that we have received is because a large number of our guardianship petitions, both emergency and permanent, have a mental illness component, or at least an alleged mental illness component. So we consider our guardianships to be part of our mental illness caseload. So my goal today is to try to break down the processes and procedures concerning involuntary commitments so that it's easy for everyone to understand, including someone who might have a mental illness and who might find themselves in need of involuntary treatment. Having served as an attorney for patients previously, it's very easy for me to see involuntary treatment and involuntary commitments from the patient's standpoint. So when I was preparing this presentation, I decided that I was going to approach it from a question and answer standpoint, because that's generally what you have to do as an attorney when you're representing someone. Your client asks you a lot of questions and they want you to provide the answers. So I'm going to go ahead and dive into my PowerPoint presentation, and I titled it Navigating the Laws and Procedures that Govern Involuntary Treatment for Mental Illness in the State of Georgia. I tried to avoid the terminology involuntary commitment because I want everyone to focus on the fact that this is really about involuntary treatment for mental illness. So the first thing I want to talk about is jurisdiction. And I want to let you all know that probate courts have authority, unless otherwise provided by law, to exercise original, exclusive, and general jurisdiction of all matters concerning examination, treatment, etc. for mental illness. I think that's very important because it can save people who are in need of help in this arena a lot of time if they understand that probate court is where you're going to need to come. You're not going to be able to go to a state court to get an order to apprehend. You're not going to be able to go to superior court to get an order to apprehend. You're going to have to come to a probate court. I now want to talk a little bit about all of the persons and entities that are involved in the involuntary commitment process. So of course, first we have the patient, who is the person that might be mentally ill and may be in need of treatment. For probate court, that person would need to be 17 years or older. If a person is under 17 years of age, they would be transferred to juvenile court. We then have the patient representatives, and those persons are family and friends of the patient or others who provide support to the patient. This information is generally pursued by the facilities. The facility is asked to try to identify 2 persons who can be patient representatives. If the facility is not able to do so, they will then need to request the appointment of a guardian ad litem for the patient. Then, of course, there is the department. So as you see the word department throughout this statute, It is the Department of Behavioral Health and Developmental Disabilities, Dbhdd. We then have the physicians and the psychologists, who are the medical professionals who examine, evaluate, and/or treat the patients. And then we've got peace officer, who is the law enforcement piece, who may transport a patient to a facility for an examination. Then, of course, we have the facilities, and those are the hospitals where the patient will be seen for either an examination, an evaluation, or treatment. We have the attorneys for the facilities, and they provide legal representation to the hospital, and they provide legal representation to the physician at a involuntary commitment proceeding. And then we have the probate court, of course, and that is where the matter will be adjudicated. And it's important to note there that it will be the county where the patient is found or where the patient resides. So oftentimes it is going to be the county where the patient is found, which is why certain counties might have numbers a little higher than other counties, because the patient just happens to be found in their county but does not necessarily reside in their county. Then we have the court-appointed attorney for the patient, and that is the attorney that is appointed by the probate court to represent the patient at involuntary commitment proceedings. And I've already mentioned guardian ad litem previously. That person will be appointed. It will be an attorney, and they will be appointed by the probate court. They are appointed to receive notice only. Now, the guardian ad litem is by statute supposed to be appointed by the probate court in the county where the patient resides. So if I have an involuntary commitment petition pending in Dekalb County and the patient happens to reside in Cherokee County, then my colleague, Judge Woods out of Cherokee County, would need to appoint the guardian ad litem. But I will also state that in some instances, Dekalb County ends up appointing the guardian ad litem because of the timing. We also have the judge and/or hearing officer, who is the person who will conduct the proceeding and render a final decision. I'm going to talk a little bit about the common mental illnesses that we see in our involuntary commitment cases: schizophrenia, schizoaffective disorder, bipolar, psychosis, personality disorders, and depression. And it is also common for us to see diagnoses that are unspecified. What are the available treatment options? So the available treatment options include involuntary treatment, which means inpatient or outpatient treatment, which the patient is required to obtain; voluntary treatment, which is where a patient signs in voluntarily; inpatient treatment, which is defined as a program of treatment for mental illness within a hospital facility setting; and we have outpatient treatment, which is a program of treatment for mental illness outside of a hospital setting. And that would include medication and prescription monitoring, therapy, programming activities, case management services, and other services. And the goal here is to prevent the patient from becoming an inpatient. I want to note here that discharge is always an option throughout this entire process. So if the patient is, 1, not mentally ill, or 2, not in need of treatment, or the patient has been stabilized with medications and is medication compliant, then discharge is always going to be an option. What are the phases of the involuntary treatment process? The first phase of the process is the emergency examination. The second phase is psychiatric evaluation. The third phase is what I'm going to call the pre-hearing and/or hearing stage. And then the fourth stage would be the commitment process, which would involve court-ordered treatment. What are the types of treatment facilities? The first type of treatment facility is an emergency receiving facility where a patient will be examined. The second type is an evaluating facility where the psychiatric evaluation will take place. And the third type is a treatment facility where the psychiatric treatment, court-ordered, will take place. State-owned and operated facilities are designated by Dbhdd. Any other facility in the state of Georgia may be designated by Dbhdd at the request of or with the consent of the governing officers of that facility. What facilities are located in Dekalb County? Of course, I'm going to talk about Dekalb County because I work in DeKalb County, and I know a little bit more about DeKalb than any other county right about now. We have Georgia Regional Atlanta, where they examine, evaluate, and treat. We have Peachford, where they examine, evaluate, and treat. We have Emory Wesley Woods, where they evaluate and treat. We have DeKalb Regional Crisis Center, where they examine and evaluate. And we also have Grady, where they examine, evaluate, and treat. I want to talk a little bit about Grady because, of course, Grady is located in Fulton County, but the city of Atlanta has a portion that is located in DeKalb County as well. So I, as the probate court judge in DeKalb County, am able to sign an order to apprehend and send a patient to Grady for an examination. So if the patient goes to Grady for the examination and the doctors at Grady determine that the patient needs to be evaluated, and then they later determine that the patient needs to be potentially seen for an involuntary commitment, and they need to file a 1021, Grady Hospital will actually file that 1021 in Fulton County because that is where they are located. So DeKalb County uses Grady for the purposes of sending patients on orders to apprehend for examinations. Additional information about all of the facilities in the state of Georgia can be found at Dbhdd's website. What are the Dbhdd regions? Dbhdd has 6 regional field offices. DeKalb County is located in Region 3, which includes Clayton, Fulton, Gwinnett, Newton, and Rockdale counties. The emergency receiving facilities for DeKalb County Probate Court are Peachford, Georgia Regional, DeKalb Regional Crisis Center, and Grady. Put an asterisk near Peachford because I want you to be aware that Peachford is a private facility and it requires Peachford's approval for the probate court to send a patient for an emergency examination. How does a person become subject to an emergency admission for treatment? The first way is by way of a physician's certificate. The second is by way of a probate court order. The third is by way of a penal offense. And the fourth is by way of law enforcement transport, which is something very new in light of House Bill 1013 that was recently passed this year. And I believe my colleague Sarah Harris told me that this came into effect July 1st. I'm going to go through each of these. So we've got the physician's certificate. You probably have often heard of a 1013. That's what a physician's certificate is. In this instance, the doctor must examine the person within the preceding 48 hours. If upon that observation, the doctor believes that the patient is mentally ill and requires involuntary treatment, the doctor will execute a certificate 1013. That certificate will expire 7 days after it is executed. Within 72 hours of receiving the certificate 1013 and a form 2013, which is a certificate authorizing transport, a peace officer is to make diligent efforts to take the person into custody and deliver them to the nearest available emergency receiving facility for an emergency examination. In this code section, when the term physician is used, I want you to know that it also includes psychologists, clinical social workers, or clinical nurse specialists in psychiatric and/or mental health. The second way that one might find themselves subject to an emergency admission is by way of a probate court order. This is also called an order to apprehend or an OTA, and it also is sometimes referred to as lay affidavits. This requires the affidavits of at least 2 persons who can attest that they have seen the person within the preceding 48 hours, and based upon their observations, they have reason to believe that the person is mentally ill and requires involuntary treatment. In that case, if the order to apprehend is signed, the person is taken to the nearest available emergency receiving facility for an emergency examination, or to a physician who has agreed to examine such person and can provide a physician certificate 1013. Just as with the physician certificate, the probate court order expires 7 days after it is executed. A peace officer who executes an order to apprehend must sign a written report detailing the circumstances under which the person was taken into custody, and that written report will become a part of the patient's clinical record. The third way that a person may find themselves subject to an emergency admission is by way of a penal offense. Now, the law on this also recently changed earlier this year. I've provided you with the former language of the statute, just so you will see has committed. That's a key change that occurred earlier this year. And I'm going to move on to the next slide and explain. So previously it was has committed. Now, based upon the revised House Bill 1013, the statute states that a peace officer may take any person to a physician within the county or an adjoining county for an emergency examination by the physician or directly to an emergency receiving facility if the person is committing a penal offense and the peace officer has probable cause to believe that the person is mentally ill and requires involuntary treatment. The peace officer does not have to tender formal charges against the individual prior to taking the person in custody. And again, the peace officer must execute a written report detailing the circumstances. Now, the big addition to this is the law enforcement officer transport, and this is OCGA 37342A2, and it states that a peace officer may take any person to an emergency receiving facility if the peace officer has probable cause to believe that the person is mentally ill and requires involuntary treatment, and the peace officer must consult either in person or via telephone or telehealth with a physician. That physician must authorize the peace officer to transport the individual for an evaluation. Before the physician can authorize transport for evaluation, the physician must determine, based upon facts available to them regarding the person's condition. They may receive that information from either the patient, from the peace officer, or from other witnesses. If the physician determines that there is probable cause to believe that the person needs an emergency examination to determine if the person requires involuntary treatment, they will be transported for such an examination. What happens after a patient is taken to an emergency receiving facility? I consider this to be the examination phase that I mentioned earlier in my presentation. So the patient admitted to an emergency receiving facility shall be examined as soon as possible, but in any event within 48 hours. So this is basically where the clock, I feel, starts ticking with respect to the hospital's duties and responsibilities. The patient may be given such emergency treatment as is indicated by good medical practice. That patient must be discharged within the 48 hours of admission unless the physician concludes that there is reason to believe that the patient is mentally ill, requiring involuntary treatment, and the physician is willing to execute a certificate 1014 within that 48-hour period, or if the patient is under criminal charges, notice of which has been given to the facility. And I'm going to talk a little bit about criminal charges on the next slide, but before I move forward, I want you to know that immediately upon arrival of a patient at an emergency receiving facility, the facility shall give the patient written notice of their rights to petition for a writ of habeas corpus or for a protective order. The patient shall also be informed that they have a right to legal counsel, and if unable to afford counsel, the court will appoint counsel. And I think it's also important to note that a physician or psychologist who previously executed a certificate 1013 on a patient can also execute the certificate 1014 on that same patient. What happens when criminal charges are pending against the patient? The patient can be discharged from the physical custody of the facility only if the facility provides written notification of the proposed discharge to the law enforcement agency originally having custody of the patient, and the patient is discharged into the physical custody of a peace officer from that agency. It's also important to note that the agency is required to assume physical custody of the patient within 5 days after receipt of notice of discharge. What happens after a certificate 1014 is signed by a physician? I consider this to be moving into the evaluation phase. Within 24 hours of the execution of the certificate, 1014, the patient shall be transported to an evaluating facility, or if the patient has been determined and certified to meet all of the outpatient treatment requirements, in which event the patient shall be discharged, or if the patient is under criminal charges, the patient shall be discharged to the law enforcement agency originally having custody. I highlighted transported to an evaluating facility because I want it to be clear that certain facilities do examinations and evaluations. So if the patient was taken for an examination and there's a determination that the patient needs to be evaluated, they won't necessarily need to be transported because they may be at a facility that can do both the examination and the evaluation. I'm going to talk a little bit about outpatient treatment requirements, but this is what my colleague, Judge Sarah Harris, is going to talk about, but I'm just going to go through this code section. When the physician at a facility determines and certifies that there is reason to believe a patient admitted or examined at the facility is mentally ill and requires involuntary treatment, that physician shall further determine and certify whether there is reason to believe that the patient is either an inpatient or an outpatient. And if it is determined that the patient is an outpatient, they need to determine whether there is available outpatient treatment. And I think with outpatient treatment, the word available is often very important. The determinations and certification shall be made within a 24-hour time period. If the determination is being made by a physician at or on behalf of a community mental health center, that determination and certification shall be made within 4 hours after the patient is examined. A person determined and certified to be 1, an outpatient, and 2, a person for whom there is available outpatient treatment shall be considered to be in need of involuntary outpatient treatment until such time as their status is determined to be otherwise. A person determined and certified to be mentally ill and requires involuntary treatment who does not meet all of the requirements for outpatient treatment shall be considered to be in need of involuntary inpatient treatment until otherwise determined. I want to talk now about an alternate process to request court-ordered evaluations. And I say that I'm going to talk about it because it's in the code section, OCGA 37-361. I've never had one of these petitions filed in my court, but I'm just going to tell you quickly what the statute states. And it basically says that any person may file an application executed under oath with the Community Mental Health Center for a court-ordered evaluation of a person located within that county who may be mentally ill and requiring involuntary treatment. Upon the filing, the Community Mental Health Center shall make a preliminary investigation, and if the investigation shows that there is probable cause to believe such allegation is true, it shall file a petition with the court in the county where the patient is located, seeking an involuntary admission for evaluation. The statute also says that any person may file with the court a petition executed under oath alleging that a person within the county is mentally ill and requires involuntary treatment. The petition must be accompanied by a physician certificate stating that they have examined the patient within the preceding 5 days and they find that the patient may be mentally ill, requiring involuntary treatment, and that a full evaluation of the patient is necessary. OCGA 37-362 goes on to describe the process that must be followed if a ordered evaluation is requested. And again, I've never seen one of these in my court. I've spoken to several other probate court judges, and I believe that they also have not seen this too often. So I'm not going to go through that because I want to watch my time so that my colleague has sufficient time to present. What happens after a person is admitted to an evaluating facility? Again, we're in the evaluation phase. The patient admitted to an evaluating facility may not be detained for more than 5 days, Saturday, Sunday, and holidays excluded. And that's very important because sometimes weekends are excluded, sometimes they are not. The patient must be discharged upon a finding that the patient is not mentally ill, requiring involuntary treatment, or upon a finding and certification that the patient meets all of the outpatient treatment requirements. So the patient must be discharged upon the expiration of the 5-day evaluating period unless they are admitted voluntary, or the patient is admitted for involuntary inpatient, or the patient is under criminal charges. I want to mention that any patient admitted to an evaluating facility may also apply to the chief medical officer of that facility for transfer at his own expense to any other approved evaluating facility. I'm going to talk to you briefly about voluntary treatment because that is very much a part of the involuntary treatment for mental illness process. The statute is clear. The chief medical officer for any facility may receive for observation and diagnoses any patient 12 years of age or older, any patient under 18 at the request of their parent or guardian, any patient who has a psychiatric advance directive in place and the request is made by their mental health care agent, any person who has been declared legally incompetent and the request is made by the person's guardian. If there is evidence that there is mental illness and that it would be suitable, such person may be given care and treatment at such facility. Such person may be detained by such facility until discharged. An individualized service plan shall be developed for such person as soon as possible. And again, any individual voluntarily admitted to a facility shall be given notice of his or her rights, as in the previous sections that I mentioned. These are required notices regarding discharge and/or transfer. So anytime a patient is going to be discharged or transferred, notice must be given to the patient's representatives, the petitioner, the physician who may have executed a certificate, to the law enforcement agency if the patient is under criminal charges, and of course, to the court that may have ordered the OTA, who may have entered the OTA for the evaluation. How is involuntary inpatient treatment initiated? This is basically what I consider the pre-hearing phase. If after an evaluation, the chief medical officer of the facility determines that there is a need for involuntary treatment, they shall direct that an individualized service plan be developed for the patient, and that must be done during the 5-day period that the patient is at the facility. That individualized service plan, and you will hear those 3 words a lot, is basically a proposal developed during the patient's stay at the facility, which is specifically tailored to the patient's treatment needs. It must include a statement of treatment goals, treatment methods and procedures, what medical staff will carry out the treatment plan, documentation of the patient's involvement, and an attestation that the chief medical officer has made a reasonable effort to meet the proposed treatment goals in the least restrictive environment possible that is closest to the patient's home community. How is involuntary inpatient treatment initiated? Patient can be detained at the facility beyond the 5-day evaluation period only upon the recommendation of the chief medical officer, and that recommendation must be supported by the opinions of 2 physicians or a physician and a psychologist who have personally examined the patient within that 5-day period, and they also agree that the patient is mentally ill, requiring involuntary treatment, but the patient does not meet the criterion for outpatient treatment. That recommendation shall be entered on a certificate 1021. The certificate shall be filed along with a petition for hearing, which is Form 1052, and it's filed in the probate court in the county where the patient is being detained for evaluation. The certificate 1021 and petition 1052 shall be filed within 5 days, Saturday, Sunday, and holidays excluded, after the patient is admitted to a facility for evaluation. Such filing with the probate court authorizes the facility to detain the patient until the completion of a full and fair hearing. What happens after a certificate 1021 is signed? Copies of the certificate 1021 shall be served on the patient and his representatives within 5 days after it is filed, and shall be accompanied by notice that a hearing will be held no sooner than 7 days, no later than 12 days, notice that the patient has a right to counsel. If the patient does not retain private counsel, the court will appoint counsel for the patient unless the patient states that they do not want to be represented by counsel. The individualized service plan shall also be included in that notice. Also, there should be notice that the patient has a right to be examined by a physician or psychologist of their own choice at their own expense, and have that physician or psychologist submit a service plan for the patient. And the notice also must include that the patient may waive in writing the hearing. If the hearing is waived, the certificate shall serve as authorization for the patient to begin treatment under the terms of the individualized service plan, and the chief medical officer of the facility where the patient is located shall be responsible for supervision of the service plan. I want to note again that the court will appoint a guardian ad litem to represent the patient if they do not have 2 patient representatives. What happens after a petition 1052 is filed with the probate court? The 1052 is filed with the probate court in the county where the patient is found. The probate court appoints an attorney to represent the patient. The probate court appoints a guardian ad litem for the patient. The probate court sets the matter for a hearing to be held within 7 to 12 days, weekends included. Notice of the hearing shall be served upon the facility, counsel for the facility, counsel for the patient, and the guardian ad litem. What is the legal standard to determine a patient is in need of involuntary inpatient treatment? In Georgia, inpatient means a person who is mentally ill and one who presents a substantial risk of imminent harm to themselves or others as manifested by either recent overt acts or recent expressed threats of violence, which presents a probability of physical injury to the person or others, or one who is so unable to care for their own physical health and safety as to create an imminently life-endangering crisis, and the person is in need of involuntary inpatient treatment. The standard of proof is clear and convincing evidence, and the burden of proof is on the hospital and/or facility. What happens at a hearing in probate court? At the hearing, the court determines if the patient is mentally ill, requiring involuntary treatment, and whether they are inpatient or outpatient. If the court determines that the patient is not mentally ill, requiring treatment, the patient must be immediately discharged. If the court determines that the patient is an outpatient, the court shall further determine, based upon the individualized service plan in place, whether there is available outpatient treatment for the patient which meets the requirements of the plan, and whether the patient will likely obtain that treatment so as to minimize the likelihood of the patient becoming an inpatient. If the court determines that there is such available outpatient treatment, which the patient will likely obtain, as to minimize the likelihood of the patient becoming an inpatient, then the court shall order the patient to obtain that treatment and shall discharge the patient subject to that order. If the court determines that the patient is an outpatient who does not meet the requirements for discharge, then the court has to take a look at whether or not the patient has been evaluated within the preceding 45 days, and if so, the court would discharge the patient. If they have not been evaluated within the preceding 45 days, the court shall send the patient to an evaluating facility. If the court determines that the patient is an inpatient, the court shall order that the patient be transported to a treatment facility and be admitted for care and treatment, which order may also require that a period of such inpatient treatment be followed by available outpatient treatment. If the court at the hearing concludes that the patient is mentally ill and requires involuntary treatment, it shall make findings of fact and conclusions of law in support of that conclusion in its final order. The court may order the hospitalization of any patient for a period not to exceed 6 months, and that is subject to the power of the chief medical officer to discharge the patient. If continued hospitalization is necessary at the end of the period that is ordered, the the chief medical officer has an option to apply for an order authorizing such continued hospitalization, but that is not done through the probate court. The court may order the patient to obtain available outpatient treatment under the additional conditions specified. The last thing I'm going to talk about before I turn it over to my colleague, Judge Sarah Harris, are the expenses associated with an involuntary commitment proceeding. So you have a judge or a hearing officer who's going to hear the case. Of course, if it's the judge, there wouldn't be an expense associated with that, because if I have to hear an involuntary commitment proceeding, I'm doing so in connection with my job. If I have to appoint a hearing officer to hear the case, then the fees for the hearing officer's time must be considered. The court-appointed attorney must also be compensated for their services. A guardian ad litem is appointed, they must be compensated. And then there's also a nominal hearing cost that must be paid. The costs associated with these proceedings are to be paid by the county where the patient is a resident. So while Dekalb may hear X number of involuntary commitment cases, half of those patients may reside in other counties. And so we send our invoices for those services to that other county for payment. And that concludes my portion of the presentation. And I'm going to stop sharing my screen.
Thank you, Judge Hargrove. That is a lot of information. I have questions that are related, but a little different in nature. The first one is, how many people that you involuntarily commit do you think also have criminal justice involvement? In other words, are on probation or on parole?
That an order for commitment is done on? Is that what you're asking?
Right, right. Or
Not
that you
total number.
just the
because-
total number, all the people. that
Well,
you-
okay. Well, the only reason why I say that is because we may have processed 350 involuntary commitment petitions, but a good number of those, 50 to 60%, the patient actually gets discharged prior to a hearing. And so probably 25 to 30% of those actually come before the court on a hearing. So of that number, I would probably say maybe 15 to 20% of those hearings, the patient may have some sort of a criminal charge or something pending against them.
Are you familiar with any data, any study of that that has been done?
I am not.
Okay, and I know that Judge Harris has a couple of questions and some statistics to share with us, and we're going to get to in just a moment. I also am interested in where you see the opportunity for improvement of the systems that you've just described.
I think there are a number of levels of opportunity for improvement. I think if you take a close look at the statute as it reads today, there's a number of things that could be done to potentially revise a few things. But from DeKalb County standpoint, I mean, given the large volume of cases that we handle, I feel that our processes and procedures seem to be working just fine. There's just, we don't have the ability to curtail the number of cases that we're receiving. So I'm really, I guess I'm sort of at a loss for words to say where there could be improvement, because the improvement from my point of view would be to have less cases coming in to my court. That would be an improvement. Now, how do we get to that? I'm not sure.
Okay, well, any thoughts that you might have on that topic, I'd love to hear at some point.
Okay.
Judge Harris, do you have any additional information you'd like to present and share with the committee?
Thank you, Judge Amaro. I know, do you want to wait on the outpatient?
If we could. I know that you have some other information you'd like to share as well.
I do. I have collected some data from the Administrative Office of the Courts, and I thought that the committee would be interested in knowing that in 2020, according to this data, and this is based on reporting from the probate courts, there were 3,163 orders to apprehend that were issued in the state of Georgia. There were probably 8 courts that didn't report any. They didn't report at all. So that's probably a little bit low. There were 1,412 involuntary treatment petitions filed. And so we already know most of those were in Dekalb County. But the other thing that it's important for everyone to realize is one of the reasons why Judge Hargrove has so many petitions in her county is that she has a state hospital and she has multiple receiving facilities and treating facilities. Across the state, every county does not have a receiving facility or treating facility. And to give you an example of that, in Bibb County, I have a CSU that's a receiving facility, River Edge, and I have Navicent Atrium Health, which is an emergency room. They have a geriatric psych unit that is a treating facility, but you have to be 55 or older to go there. They are a Dbhdd treating facility. We also have Piedmont Hospital, who has an independent behavioral health division and unit, but they are not a receiving or treating facility under Dbhdd. So I can't send to them and they don't file any petitions for involuntary commitment. So last year, Bibb County had 11 involuntary commitment proceedings. And in the last 12 months, we did 72 orders to apprehend. And it really varies by county. To give you another example, Troup County had 121 orders to apprehend, and it's a population of only 60,000. So the numbers are all over the place depending on where you're located. And I just thought, in line with what Judge Hargrove had presented, it would be interesting to hear those statistics.
Thank you, Judge Harris. I'm left wondering about the way in which superior courts and probate courts overlap. Obviously, we have mental health courts, drug courts, veterans courts. I presided over a veterans court meeting this morning. And are there any ways that you could envision that there would be either statutory fix or change or some other approach that would allow for greater collaboration in this space between the two classes of court? And how would you foresee us sort of cooperating in order to deal with people that might be in each other's systems?
I think before we make any additional changes to the mental health code, I frankly believe that it needs to be redesigned as opposed to rewritten. I think that there are a lot of safety nets, and there should be, because patients should have due process rights. But it is extremely hard to understand our current involuntary mental health code. And before we start adding other layers and doing anything, I think we need a complete analysis of that code section. We do not have the benefit of case law because these cases aren't frequently appealed on some of the procedural issues. So there's not a lot to give us any instruction as to what we can and can't do and what's correct. So I think that's the starting place. I also think we need to look at the cross section. I do think if there were a way to have Superior Court or the Sheriff's Office and DA's office divert those first people coming into the criminal justice system to the civil commitment side, if we could work together to do something like that, that would certainly help catch some of these people early on before they start going through the system over and over again, or as we often see, they're stuck in the jails for extended periods of time, waiting for forensic evaluations, waiting for those kind of determinations. So if we could find a point early in the process for Superior Court to divert to the civil commitment process, I certainly think that would be helpful.
Let me give you an example of a case I was working on this morning, where a defendant who's charged with entering an automobile and theft by taking. In other words, he went into a vehicle and stole, or is alleged to have stole a cell phone and some currency. So this person was arrested on 6/26 of 2020, all right, June 20th of 2020. We had a competency evaluation order signed on October the 9th of 2020. He was deemed incompetent to stand trial, but restorable on 11/17 of 2020. He was ordered to be restored on December the 15th of 2020. He was admitted to the Central State Hospital on 7/21 of 2021. He had a 90-day evaluation performed on October the 25th of 2021. We got a 9-month update, or promise of a 9-month update from the department on 7/25 of 2022. And we haven't received the final report yet, but we have been informed informally by an email that he is incompetent, and a formal evaluation will be coming within a couple of weeks. We haven't seen the final evaluation. So this person has been in jail since June the 26th, well, in jail or in the Central State Hospital since June the 26th of 2020. The charge hasn't gone forward at all. And the case is one of entering an automobile and taking a cell phone and some US currency. So this is an example of something that we're trying to avoid. And when we talk about collaboration between the probate court and the Superior Court, wouldn't it be wonderful if we could have somebody like this addressed early on and transferred to the probate court for some sort of either a AOT program or something else that connected them to treatment and diverted them there. In any event, that's one of the reasons why we're spending so much time focused on your system, Judge Harris, Judge Hargrove, and any kind of suggestions that either of you have to stitch these two things together to allow for better outcomes for people who are in my situation, I'd greatly appreciate hearing. And I know that I almost said Judge Bailey. Dr. Bailey is going to be taking a look at this space a little bit at a meeting that we've got coming up, hopefully sometime at the end of September, maybe October. What's interesting about the facts I've just described, Dr. Bailey, is that if we assume that this person is not restorable, then at that point, there is an evaluation to determine whether or not they meet civil commitment criteria, correct? Whether it's inpatient or outpatient.
Yeah, and I think, there was legislation this year that proposed misdemeanors, which is even lower than what you were saying, wouldn't go into the hospital system. We could do this on an outpatient basis. And that didn't pass, or it didn't go through. And I think that's what we need to look at. Low-level crimes and misdemeanors. We shouldn't waste a year, because when they're in the hospital system, people don't realize they're spending all their energy trying to make the person competent. And what I've seen a lot of times, takes them a long time to get in there. They make them competent, and then the charges are dropped. And it's just this waste of time when really what the person needed was treatment. And so we went through this criminal competency, and we need early on to decide, do we really want to prosecute this case, or do we really want to get treatment? If it's murder, we really want to prosecute. If it's a low-level theft, and we know they're mentally ill, we really want to get to treatment. And we need to separate those, because we waste time and resources on the wrong thing.
Well, we want to get Dr. Bailey's perspective on this in a full-hour presentation, maybe in 6 weeks. As much time as you need in order to prepare it to present, just let us know, Dr. Bailey, and thank you for being willing to do so. Judge Hargrove indicated that Judge Harris would make a presentation on outpatient commitment. And that is true. It's just not going to be today because we're running out of time, and Judge Harris has graciously agreed to do this at a point in the very near future. She's on vacation to Africa, and there's a lot to be said about that. And we hope that she has a wonderful time. But when she comes back, she's going to be able to give us some insight into the outpatient side. On September the 1st, you haven't received the agenda yet and hasn't been approved yet, but we're looking at hearing from Piedmont Healthcare System. We're also looking at hearing from Accenture about some data sharing, some work at Intercept Zero. I'll make sure that everybody gets what they need in order to look at those topics and look at those presentations in advance of the meeting that we have on September the 1st. I hope that you'll all be able to make it. Last thing I'll say is that if you're looking for some of the exhibits from today, in other words, some of the presentations, all of them are available through my secretary, Lynn Chambers, who's on the call. All the subcommittee members should have received them already. But if you haven't, please reach out to Lynn. She'll be sure that you get what you need. Thank you so much to all of the presenters who've done such a great job of explaining to us their role and in this complex system. We've learned a lot today. Do we have any other questions before we break?
Judge Amaro, I just want to say that I will email Ms. Lynn Chambers the latest draft of my presentation. So there were some changes that were made.
Okay,
since
that sounds great. We'll get it out to the group. Thank you again, Judge Hargrove.
I'll email it this afternoon.
Yes, ma'am. Thanks, everybody. And we're adjourned.